Thank you. So I'll start sharing my screen. Did anyone go through what learning tasks I had given you yesterday? Anyone who's read about it? Learning outcome 5 was understanding the principles of care planning. Can you hear me and see me, my screen? Can you all see my screen as well? Know what happened? Yeah, I hope you can see my screens. If you can, please just you can write it as well if you can't speak. Yeah, thank you. Okay, so brilliant. We were studying about understanding the principles of care planning. We'll be doing this learning outcome 5 today, and we will also complete learning outcome 6, which then takes us to the 11th of October, that is next weekend, Saturday, when we will have a discussion on our assessment. So I would highly recommend everyone to attend that session. The reason is because it's got all your questions and answers there, whatever you have, whatever questions you have regarding your assignment. So if because you're working, if you can't attend, that's understandable. You can see the recordings, but it's always best to attend. If for any reason, again, if you can't attend, it's okay. You can see the recordings. And if you have any questions, please feel free to email us. And I'll just share the email ID again for your reference. So it's learnerwork@ukversity.co.uk. Okay, that's you learnerwork@ukversity.co.uk. Just save it for yourselves if you have any questions related to the course or to the assessment, anything. Okay, so we will start. We were talking about care planning yesterday, and we were talking about the purpose of care planning, and how flexible care plans should be. And then there was this idea about what does a care plan include. We had talked about this. Um, so it should be very whatever type of care plan you have, it needs to be taking into consideration the person themselves. Okay, so you'll have different people, and you need to make the plans according to what they need. So it's centered to them. Mental Capacity Act, we had talked about this. Then yeah, so we were talking about the key differences between traditional and person-centered care. Anyone who's gone through this? I had shared this uh, snip tools with this snapshot with you guys. Has anyone gone through this? What is the difference between traditional care planning uh, versus person-centered or mental capacity um, act complaint care planning? Anyone? Has it no one gone through it? If anyone could just text it, it's fine if you can't speak. No? Yeah, someone speaking. Yeah. Your voice is not so clear.
Now.
Yeah, I can hear you now.
To worship Him today. That includes our tithe, offering for this service, transportation seed.
Mm-hmm.
That kind of seed you have prepared to worship God.
I don't get it what you're saying. I'm sorry. Okay, so we'll quickly go through this if no one has anyways. whenever you're getting something from the tutor to read at home, please make sure you spend only 5 minutes. That's enough. You can open it up. It's open in front of you. You can just read through it. It's not very hard. So I would appreciate whatever is given to you for your work at home. Please, please, please do take it seriously, because this is always going to help you in your assessment, if not anything else. So the personal, in traditional care planning, there was the professional who assesses the person's need. It was always it was always like the doctor, the GP who was assessing in person centered in sorry in the traditional care planning, whereas in the person centered approach, there was care and support plans that were developed with the person, and the conversation was led by the person. So the person was in conversation with the system or the GP, and whoever's in interaction with them. And it was always that care plan was led according to their wishes, according to their needs, their requirements, their preferences. Care planning initially in the traditional care planning system was followed a medical model of disability, whereas the care planning now, when it's person centered, it follows a social model of disability. Initially, there was a focus on what the person was unable to do. So they've worked on that, and in person-centered approach, the focus was is now on goals and aspirations, what the person would like to achieve with their care and support. In the traditional care planning, there was a static view of the person's ability or capacity, whereas in person-centered approach, the care planning explores potential for change, opportunities to develop capacity and ability. Initially, it was the professional who wrote the care plan, and they had little or no input from the person or any of their relatives or their representatives. Now, what happens is that the person is supported to express how they would like their care, what time, what place, how frequently. So, whatever is possible, it is done for them. The professional provides information about what the service can offer, the agreement, what will be in the care and support plan, and a copy of the plan is made available to the person or their representative, whoever has the capacity to have it. The emphasis initially was on protecting the person from risk, and the process took place when it was convenient for the professional, not looking at the convenience of the person they were caring for, and power was with the professionals. Whereas now the emphasis is on safe care that respects a person's rights to take right to take risks, that they understand the care planning conversation takes place now at a time when the person is most likely or more likely to have the capacity, and power is equally shared. Okay, so now we go and outline the responsibilities involved in care planning. So it's multidisciplinary. We had talked about all of this, that there can be all of these, any of or all of these people who are involved in the multidisciplinary approach, where you're caring for the person. The nurse aids role. So there's this team that shares its experience regarding the patient's progress, and the nurse encourages the patient to speak to the team regarding observations and concerns. So the nurse shares information regarding general status and mood of the patient, difficulty with meals, bathing, etc., concerns that she has regarding the patient's safety. When they found a gap in patient safety and difficulty with eating his meals, the nutritionist plans to see the patient for a specific evaluation to assess swallowing, for instance. The nurse explains that to ensure the patient gets enough to eat and eat safely, the patient will be assigned to several new tasks, including that are included in the patient's care plan of care. As the patient nurse aide, she will ensure that the patient is out of bed and sitting upright during meals to prevent choking. Now, they're all for this person who can choke. Okay, it's not it won't be for everyone. It would only be for this person. Okay, it can be for others also, obviously, but it is tailored for this person. Uh, and assist the person during meals by cutting larger portions into smaller sizes and opening challenging containers, which they can't, monitoring completion of meals to document his nutritional intake. What are the responsibilities of a care worker? We had talked about this, all of this. Okay, so a care worker helps at home, getting dressed, providing the company, providing company, chatting and sharing news, involvement with writing residents' care plans, providing information to family members regarding this care plan, ensuring that the patient's or residents' needs and wishes are met. I think we've done all of this earlier. So we were on this, the care plan, and I had discussed this as well, the care model care planning process. Uh, and then this was to describe how to ensure that the individual is involved in all stages of care planning. So it was through evidence that we saw through research that supporting patients to be actively involved in their own care, treatment, and support can improve outcomes and experience for patients and potentially yield efficiency savings for the system through a more personalized commissioning and supporting people to stay well and manage their own conditions better. So the law is clear that you must be genuinely involved in planning your care and support. This means that you are the person who knows best what your needs are. You should play an active role in planning your care and support. The process is described as person-centered and person-led. Now, this plan belongs to you, and the planning process is about you. So, your care and support plan should set out what your needs are, how your needs will be met, and how the plan will help you achieve your needs and wishes. Someone from the local authority will work with you to prepare this. Now, your care plan your care plan will be reviewed, and from time to time it can be changed. The purpose of reviewing your plan will be to monitor progress and changes, consider how the care and support plan is meeting your needs and allowing you to achieve your personal outcomes, keeping your plan up to date and determining what, if any, services might be needed in the future. Sorry, your care and support plan should be reviewed every 12 months. Sorry, just give me a minute. Now, how is the review carried out? So it is a self-review. This is when you review your own care plan. Okay, and you submit it to the local authority for them to sign it off. This method is generally only appropriate if you have a stable, long-standing support package with fixed or long-term outcomes. There's a peer-led review. This involves a group of friends. So peers will be your friends or family members that are helping you to review the plan. Review from a distance. This could be done on phone or online. Face-to-face review can be done, obviously, with your social worker and go through your plan. Your local authority must involve you when carrying out the review. If you have difficulty involving yourself in the process, then the local authority should appoint an independent advocate for you. It should also involve your carer, uh, your family, anyone else you request, if that is appropriate and what you want would be followed. We had not discussed, this was a case about Mr. M. Oh, Miss M. Sorry. Did anyone read this? That's fine. I would appreciate if you do come after reading it. So M is a 67-year-old woman. What are we talking about? Practice example, okay? And she had a mild mental health problem and lacked capacity to decide where to live. Okay, she had substantial medical needs that included her being a diabetic. Well, it was not well controlled. She was placed in a care home by the clinical commissioning group. It considered this to be in her best interest because of the significant risks to her health if she returned home. Although home is obviously the best place, your family members, yourselves, you would love to stay at home, even if you're getting the care. But that care will not be of that, um, it won't be adequate. Um, And M hated living in a care home. She wanted to live in her um, in her own home, or she would take her own life. It was so bad. She wanted to leave that place. While acknowledging these risks, the Court of Protection said that if she remained in her care home, she was entitled to ask, what for? Why am I living here? The right to life and the state's obligation to protect it is not absolute, and the court must have regard to the person's own assessment of their quality of life. If her case, in her case, there was little to be said for a solution that attempted to preserve her daily life without meaning or happiness. Now, when you involve, there's an involvement in the cycle of care and support plan. What happens? It's not an isolated activity. There is ongoing communication between, sorry. So there is a constant communication between, what's happening? This is going strange with my screen. So there's a relationship between the person and the care professional. We'll come to this. However, involvement of any type of involvement in the cycle of care and support plan, it is not an isolated activity. It has multiple people involvement. That is why it is multidisciplinary. It enables decisions to be altered over time to reflect a person's changing needs. Whatever services there are, they should look at some of these factors, like at the outset, when developing the plan of care for each person as part of the risk assessment, risk management process, including safeguarding each and every time care and support are provided when carrying out reviews through regular feedback about people's experience of the services that they receive. This should all be part of the ongoing conversation that takes place at all stages of care and support planning process. So what happens here? The relationship between the person and the care professional. What is what should be happening there? There is gathering of information, identifying their wishes, feelings and goal of the person that you're caring for, exploring the actions, assessing risks and benefits, agreeing the plan with what with will be provided and how it will be provided, delivering the care and support plan in line with the person's wishes, and monitoring and reviewing, seeking and listening to feedback. So all of this should be involved in the care plan. Now we are coming to analyze ways to overcome barriers to implementing care plans. So they can be barriers. We will talk about these. Such barriers include the staff's lack of skills in managing advanced directives, certain beliefs or prejudices, that can be there. Previous negative experiences in relation to decisions at the end of the person's or patient's lives. All these issues make it very hard, and they act as barriers. Now, if you can see in an advanced care planning, so there are different processes that think, talk, record, discuss, and share. So when thinking, you think about your future, what is important to you, what you want as a patient or a person who's receiving the care, what do you want to happen or not to happen if you became unwell. Just think about it. That is the first process. The second step is to talk to families and friends and ask someone to be a proxy spokesperson or lasting power of attorney. It's if you could no longer speak for yourself. Okay, write down your thoughts as your own advanced care planning. Okay, advanced care planning obviously is takes into consideration the time when if you're not you're still okay, but what if something happens to you? What will you do? Who will you assign to talk on behalf of you? So this is recording. Then it is discussing your plans with your doctor, nurses, or carers, and this includes a further discussion about resuscitation. Um, so do you want a DNR, or do you want a respected way of dying, or refusing further treatment? And share this information with others who need to know about you through your health records or other means, and review it regularly. So people, when they're not even, they're not dying, but they decide how they want to die best. They want to donate their organs or stuff like this also can be discussed earlier. How to overcome these barriers in care planning. So this was something that we had discussed, what is advanced care planning. Now how to overcome these barriers that we had talked about. Improve diversity. So if you have more diverse healthcare workforce, this will give more opportunity to the patients to receive care from someone who shares their own race or ethnic background. So, for instance, if there's a Christian, your religious beliefs will align most closely with a Christian um, uh, uh, carer for you. Apart from that, if you're white, if you're from white race, you would prefer someone from, because it's easier to communicate, you feel for that person better. And there's some errors that everyone could make in terms of ethnicity, in terms of race, in terms of religion, in terms of, even as, and I would say, if there's a young person and they want some lively someone lively to talk to. So if there's someone according to their wishes, you could have someone, doesn't matter if they're old or young, if they're lively enough, that's okay. If there's a person who's very serious, the patient, and they don't like to chat too much and they like to be living on their own, you could have a person who's less, I would not say less lively, but more reserved and more um, like someone more of a senior age, because a young person as a carer would not be able to. So it will become hard for the carer as well. So you want it to be easy for the patient and for the carer. Okay. uh, so a study found that patients were more likely to give the maximum patient rating score and were more compliant with treatment regime when they identified with the person's ethnicity. This is what research has, this is not what we are saying, okay? In addition to hiring a more diverse workforce, hospitals must also collect information regarding the patient's ethnicity and those steps that are necessary to take ethnicity into account in a patient's care. Embrace innovation. One more way to overcome these barriers. So the healthcare should be preparing a care plan. So the healthcare industry needs to think outside the box, not only when it comes to improving care, but also reimbursement for care. So the patient-centered care is increasingly delivered in teams, both within the healthcare system and through referral systems. Relationships with other organizations. A lot of work goes on behind the scenes that is often not reimbursable. So that time needs to be reimbursed. Developing an innovative system that rewards collaboration will help undo a payment system that does not adequately compensate for this work. Collaboration with community organizations. It's well said that it takes a village to raise a child. So it rings true for organizations that have embraced person centered or patient centered care planning. When they're hospitals, they think that they are the be all end all for their patients' care. But in reality, there are many people and organizations like schools, food banks, local agencies that contribute to a person's health. Hospitals must change their focus from protecting their volume and growing their service line to embracing their role as a contributor, not the sole dealer, to the health of their community for the sake of their patients. Serve the whole patient. So, transforming the culture of an organization to deliver care in a way that better serves the whole patient as a complex is it's a complex endeavor. And to put a patient's need first requires that the organization will be willing to put its own needs on the second place. And this is a commitment within the organization to permit staff to address patient needs as they arise, even if the service is not in their job description. They should be doing it. So it sounds good on a mission statement or a strategic plan. However, it will require hospitals to invest in training their staff and creating a culture that focuses on customer service and respect and patient empowerment. Rethink compliance. Just a minute. Just see how far are we. Yeah, that's fine. Just 3 slides. Sorry. Yeah. So when we rethink compliance, we know that we have to comply by the rules. Regulations, whenever they are in place, they are meant to ensure that all patients receive quality care, and they have unwittingly turned the healthcare industry into a tick box culture, unfortunately, where hospitals are incentivized. They get incentives to providing care to the lowest common denominator to keep agencies off their back. There is something for healthcare leaders to ponder in Amazon CEO's statement to stakeholders in 2016, where it was said that good process serves you so you can serve your customers. But if you are not watchful, the process can become the thing. This can happen very easily in organizations. The process becomes the proxy for the result you want. You stop looking at outcomes and just make sure you're doing the process right. So, in a healthcare system as well as in the tech sector, the process of ensuring regulatory compliance can too easily become the thing only. And this must change uh, for clinicians and for hospitals also. And as a result, care can become embraced, uncumbered and slow and legalistic rather than being dynamic, being changing, being centered to the patient and friendly. Okay. So it's just a tick box that you have and nothing else. So it's just a robotic way of treating the patient and not considering the human element. So, when you have the patient centered care organization, they must not be held hostage to meeting regulatory requirements. Instead, they should look beyond the minimum and understand their patients when designing a patient centric model that not only surpasses the minimum requirement for compliance but also delivers clinical excellence. Now we go on to critically reviewing the challenges of developing care plans that meet the needs of the individuals and their agreed outcomes. There are plenty of factors that can make a care plan not fit for purpose. The first reason is that your care plan doesn't have any involvement in the patient is not involved. If information within the plans isn't specific in setting out the needs of the person in care, the goals you want to achieve or to support or the support that they require. The next biggest problem is that the care plans are too complex or too brief to be useful to frontline staff or external stakeholders like inspectors or GPs. The information within it is either misleading, non factual, or it can be both. The care plans are not focused on the wider holistic needs of the person in care. A really big problem is that contain sarcasm. Unfortunately, rude or offensive terminology. They focus solely on the disabilities of a person rather than their abilities. The biggest and the worst problem is that they are too often not evidence based. This is overview of the challenges. We've talked about these challenges in detail. These are some of the references that you could follow. Any questions related to this fifth learning outcome? Does anyone have any questions before we move on to the last learning outcome? No? If you have any questions, feel free to write in the chat box. I'm happy to take them. Now coming on to the sixth learning outcome. Just give me a minute. I hope you can see my screen.
Yeah.
Yeah, thank you. Okay, so unit 4, the last learning outcome is understanding safe administration of medication. What do you think comes under the safe administration of medication? Any rules that you can think of, any steps that you can think of, any prerequisites that you can think of? Anyone?
Wearing gloves to
Very good. Mm-hmm.
face masks to
Mm-hmm.
stop breathing, covering up your scrubs.
Very good. Yeah. So, and then we'll read more. Thank you for your comments. Um, so, has anyone encountered any time any person who's seen an unsafe uh, way of administering drugs? Have you ever
Yeah,
seen? Yeah.
yes, please. You being a senior, giving one's medication to a carer to give it to
Mm-hmm.
the service user whilst you
Mm-hmm.
are away. Uh,
Okay.
That one to be unsafe ministry.
Mm-hmm. Okay. Very good. Yeah, that could happen. What else?
And please, at the same time, refusing to give the medication, the service user's medication on
Okay.
time.
Okay. Okay. Yeah. Mm-hmm. Yes, on time. So sometimes what happens, because there a long list of medications, or you may have a long list of patients, you might it is possible to have a human error, right? So what happens when you're not focusing too much on like properly doing it, or not properly documenting it? What happens with this lack of documentation is that you might miss a lot of points, like someone who is not allowed to take drugs through, um, like orally, they can't take drugs because of choking hazards. Okay, so you might miss out that information. So reading that information, or taking that information, and then doing things according to that is very, very important. So that needs to be end up in not in the patient's best um, interest. My internet connection is unstable. I've just seen, because it's very windy over here in Bolton. I'm sure it's windy everywhere in the UK. Stay safe, everyone. Yeah. So, the learning outcome 6 focuses on the statutory requirements in relation to mental health, mental capacity, children and young people. We'll talk about these. We'll talk about analgesics, about antibiotics, antidepressants. How do we give them? What is the safe way of giving them? What are the ways, like what routes are you following to give them? Checks carried out in relation to medication, patient name checks, as I said, read their records properly, analyze standard precautions for infection control for the administration of medication, use PPEs, hand washing, correct disposal of items used, reporting and recording, and risk assessment, records of receipt of medication, medicine administration record charts. We'll talk all about these, just to inform you. What is medication? So it is a dosage that contains one or more active or inactive ingredients. Thank you for all those who spoke on my question. I really appreciate it when there's, because I teach live students, and it becomes very difficult when you're doing it online, and you don't have, actually, you're not listening to anyone, and you don't know if the person who's listening to you has actually understood the concept um, or not. So just a thumbs up for you all. Thank you. So yeah, so the dosage that contains or the dosage form that contains one or more active or inactive ingredients. So the medications come in many dosage forms. These include tablets, you have capsules, you have liquids, creams, and patches. Some medicines for minor illnesses, they can be brought over the counter without a prescription, so you can treat yourself without needing to see a general practitioner. Simple painkillers and cough remedies, for instance, can be brought directly or bought directly from supermarkets and other stores. There are other types of medications like eye drops or emergency contraceptives. They are available again without a prescription, but they need a pharmacist supervision. So you're only are only available to buy from behind the pharmacy counter. The pharmacist may ask you several questions to make sure that the medicine is suitable for you. There's some prescription only medications that must be prescribed by a qualified health professional. Just give me. Okay, sorry. There's someone who's writing on the board, which I would not want. Uh, okay. Yeah, sorry for that. Okay, I would appreciate if you don't write here because this is a recording session. Yeah. So other types of medications such as eye drops or emergency contraceptives, they are available without. Okay. So pharmacy prescription only medications like antibiotics must be prescribed by a qualified health professional. This may be a GP or a personal or a hospital doctor, a dentist, nurse, pharmacist, optometrist, whoever has the authority, okay, or a physiotherapist or a podiatrist. There are 7 R's of medicine administration. Okay, always remember this. So these 7 R's are: is the medicine for the right person? Whenever you're giving the pen medication, just read these things. Okay, is it for the right person? Are these the right medicine for the individual as per their charts? Is this the right dose? So you know the right medicine, the right person, and the right dose. And next is the right time. Is it given morning, before meals? Is it given after meals? Is it the right form? Like, is it liquid? Is it a tablet form? Is it nasal? Is the medication or medicine being administered through the right dose? And is the medicine bringing improvement by providing the right outcome? So this is longer term. Rachel, I hope, I'm sure this must be kids. I would appreciate if you don't, if you just try and not write on this. Thank you. So administering medication, what is medication administration? I'll have to. Okay. So what is the proper way of this is distracting me. I'm sorry. I would appreciate this. That doesn't happen in an online class. Rachel, if you're there, or if there are kids there, please, I would highly appreciate if you could if this could be stopped. Thank you. So what is administration of medication? So it's simply the route the medication takes to enter the body. The medicine can come in many different forms, and the method of administration differs depending on this and the illness and the patient's needs. The 6 most common routes are oral, rectal, inhalation, nebulization, transdermal, and injection. These are the 6 common routes. I'm not going to go into details. Okay, you know what forms these are. Okay. So this now we go on to describing the common types of medication and their effects and the potential side effects. So the according to the Medicines Act 1968, it classifies medicines into three legal categories. So that's general list. Just give me a minute. Anyways. So there's a general list medicines, GSL, that can be sold in supermarkets and do not require a pharmacist to be present, like paracetamol, vitamins, it's cod liver oil, for instance. Pharmacy medicines, which must be sold only in pharmacies and under the supervision of a pharmacist, such as ibuprofen. Uh, if there are more than 16 tablets, or aspirin. Prescription only medication. So this can only be obtained if with a prescription from a pharmacist or a doctor, like certain antibiotics. So in total, there are three types of medications. General sale list medicines, pharmacy medicines, and prescription only medicines. Okay. Apart from this, there are other types of medications also. There's following categories. So there are antibiotics that you use for infections, analgesics to relieve pain, antidepressants for depression, controlled drugs that must be prescribed by a doctor or another qualified person. Other drugs are used for treating other conditions like antihistamines or antacids. Non-prescribed medication is used for treating minor symptoms, such as homely remedies such as honey and milk for cough. Common types of medication and their effects and potential side effects. So antibiotics, they're here as amoxicillin. Its effect is used to kill bacteria and virus, obviously bacteria, not viruses, sorry. You can have these potential side effects such as diarrhea. You could have all sorts of these side effects. So not everyone has them, but some people can have these side effects. Swollen pain, stomach pain, sorry, nausea, vomiting, headache, swollen glands, etc. Analgesics like aspirin, painkillers, and they can give you a heartburn, upset stomach, drowsiness, or headache. Antidepressants such as amitriptyline is used to treat symptoms of depression. They can cause constipation, diarrhea, nausea, vomiting, mouth pain, rashes, changes in appetite, or change in weight. Some control drugs such as Ritalin um, can are used to treat conditions like attention deficit hyperactivity disorder, ADHD, or narcolepsy. Okay, by affecting the chemicals in the brain um, and the nerves that contribute to hyperactivity and impulse control. What do they develop then? You could have symptoms of these adverse symptoms like fast heart rate. You could have insomnia, like you can't sleep properly, loss of appetite. There's other symptoms like nausea or stomach pain, etc. Um, what is narcolepsy? Does anyone know? It's a chronic condition with the neurons. What happens that it affects the brain's chemical um, balances or regulation, and there's a disruption in your sleep and waking cycles, and there's excessive daytime sleepiness, and there's sudden muscle weakness, that you could have sleep paralysis and hallucinations also. So you sleep at during the daytime. There is ability to so you can't regulate your sleeping and waking times. What are some of the symptoms? There's excessive sleepiness, um, muscle paralysis, sleep paralysis. There's a brain fog. You don't understand what you're doing. This happens when you can't sleep properly at night. Other drugs like antacids, like Gaviscon, they're used to treat heartburn and an upset stomach. They can cause constipation or diarrhea. Non-prescribed medication such as homely remedies, there's clove oil or honey, for instance. Clove oil is used to relieve tooth pain. It can lead to hypersensitivity of the teeth or irritation inside the mouth. So the different routes of medication administration when you're administering them, what are the routes and form used in the individuals? It depend on in the individual's preferences. For instance, they may prefer to take their medication in tablet or a form rather than capsule form. Their needs, for instance, they may find it difficult to swallow tablets and therefore they may take it orally. They may take it in the liquid form, and the individual conditions like are they awake, or some may be intravenously that you may want to administer, or topically. What I will do is these are some of the routes of medication, and if I start them, it's going to last me beyond this um, time for our finish. So what I'm going to do is that I'm going to leave you now. And what we will do is that we will discuss our assessment next week, and we will also discuss this last outcome. I will appreciate if you could stay here for